We are back. It's APHA's virtual annual meeting and expo. Today, we'll be catching up with newsmakers at this year's meeting and looking ahead to the future. Stay tuned. I'm Dina Baer, and welcome to our final day of APHA TV, covering this year's virtual annual meeting and expo. Today, tune into the closing general session, participate in networking and engagement activities, check out the session Owning a Historical Trauma, and please participate in a post-meeting survey to tell us your thoughts about this year's event. Incoming APHA President, Dr. Jose Ramon Fernandez Peña, is here now. First of all, let me say congratulations on being the incoming president. Can you tell us about your plans for the year ahead and how COVID-19 is playing into that and your campaign?
Thank you for that question. In the year ahead, I want to focus on the importance of the lack of diversity in the health workforce overall, and certainly in particular in the public health workforce. I think that it's a very important aspect that we need to be mindful about as we try to achieve a better equity in terms of health outcomes, especially with underserved communities. COVID certainly figures prominently in this conversation, as we have seen sadly how the lack of parity between public health workers, for example, contact tracers, and the community needing to have that information has been a challenge in achieving what we needed to do in terms of communicating effectively with the populations that have been hardest hit by COVID-19.
I know racial health equity is an important issue for you. Can you tell us why that is and the work you plan to do in that space?
In the year 2001, I launched a program called the Welcome Back Initiative, where we work with immigrants that were health professionals in their countries of origin, come to the US for whatever reason, and end up working at McDonald's or driving taxis. So programs work with them to help them re-enter the health workforce in some capacity. Ideally, the one they had in their countries of training or the countries of origin, but at least not working at a restaurant or making beds or taking care of babies or old people, and instead bringing their skills, knowledge, and languages into the health workforce and infuse it with such needed diversity.
You're also focusing on the lack of diversity in the U.S. health workforce and its impact on health outcomes. Tell us a little more.
If you look at the kind of communication or the strength of the communication, the trust that can be established between a health services provider and a community that is being served by said person, parity in terms of cultural language and other kind of qualifiers is a strong predictor of, for example, continuity of care, adherence to medication regimens, adherence to treatment plans, adherence to health education, expected health education. When you're able to explain to somebody in a way they understand or they can trust why it is important to bring the kid back for the second or third round of immunizations, or when you're able to explain to somebody why they're letting you know how many people they have been in contact with so that we can do adequate contact tracing, and that you're not putting people in jeopardy for X or Y concerns that the population may have, you're more likely to be successful. When you see yourself reflected on the person or the people who are treating you, you are oftentimes put more at ease in terms of achieving that connection. If a transgender person can meet with a provider that may understand their journey better than a cisgender person, this patient is going to be hopefully more comfortable sharing their concerns about their health and what they need to do to stay on the path that they want to be.
Let's begin with our daily tour of organizations doing the very best work in public health.
The Global Infectious Diseases Institute was founded in 2017. Our mission is to stimulate, catalyze, and support new interdisciplinary research on infectious diseases of worldwide significance and prominence. And we try to foster interdisciplinary research by bringing together faculty from across the campus and a variety of disciplines.
The Global Infectious Disease Institute really tries to match new groups together. We need to get people thinking in different directions, and so we have brewing sessions, which are engaged dialogue and facilitated questions and interactions, solving problems they hadn't been thinking about before because we really want them working in new areas. And then we'll have calls out for seed funding to help them get started in doing that.
I think the COVID epidemic that we're currently experiencing has revealed to us that you can't just focus on science or medicine to solve this global problem. It takes all disciplines in order to tackle these notorious challenges.
The Johns Hopkins Center for Gun Policy and Research was established 25 years ago with a grant from the Joyce Foundation. The mission of our center is to reduce gun violence in America and promote justice and equity. A foundation of our work and our ability to have impact is really based upon the scientific rigor of our research.
Prior to the mass shooting at Sandy Hook Elementary in December 2012, there was very little public opinion information on gun policy, but in reality, there was really just an information void. I'm very proud of the work of Johns Hopkins and our center for being able to step in and begin a rigorous research approach to trying to better understand the contours of public opinion on gun policy in America.
Whether it's groups that are marginalized because of their documentation status, because of their race, because of their sexual orientation, everything that we do is geared towards enhancing their right to health.
Without data and without actually pushing for change, that change will probably never happen. And so having access to research, having access to a good department like ours is absolutely critical to improving the health status of people everywhere.
We have faculty that are social scientists, faculty that are epidemiologists, lawyers, and so that inherently injects an interdisciplinary and multidisciplinary lens in the research approach.
The department has never been more robust, and our students have never been more enthusiastic. We see ourselves as partnering with the community to make change and improve health outcomes.
I'm the director of the Center for Health Equity at the Louisville Metro Department of Public Health and Wellness. Our mission is a Louisville where everyone in every community thrives by expanding our reach when it comes to advancing health equity across our community.
Racism is a system that concentrates power for some by concentrating scarcity for many. So racism is fundamentally depressing the quality of life for all of us and reducing our ability to experience joy and wellness because our systems are designed around unfair power. The Center for Health Equity tries to advance health equity in a few ways. We analyze data to be able to tell the story. We try to support our partners, and then we really try to help shape a worldview for people that says we do deserve better.
My name is Michael Bird, and I'm Kiwa Pueblo from New Mexico, and I'm past president of the American Public Health Association. The session I am doing for APHA is titled Owning Historical Trauma, Precursor to Strengthening Public Health. Basically, it's looking at the historical antecedents that have brought us to this point in terms of violence and part and parcel, as I see it, COVID and its implications for Native populations, as well as African American and other communities of color. Of any racial or ethnic group, American Indians and Alaska Natives have the highest mortality rates from multiple chronic conditions, including heart disease, stroke, liver disease, kidney disease, lower respiratory disease, and diabetes. They also report the lowest self-rated health status and have the shortest life expectancy of any racial or ethnic group. Needless to say, if that's where we're starting out from, COVID clearly has significant implications and impact on Native communities. Unfortunately, because of our small numbers, we tend to be invisible and don't get the attention that other communities do. American Indian communities have been subject to more violence than any other population in this country. Present circumstances, the United States government made under treaties made obligation and commitments to Indian people in this country, and unfortunately through the Indian Health Service, the level of funding for Indian people has only been at 50% of the level of need. I think the other thing is one of the polite terms that's used is comorbidities for communities. It's a polite way of really not addressing the real issue. The real issue is historical trauma. The real issue is poverty. The real issue is racism. APHA as an organization is based on a number of values: equity, diversity. And I guess what I would say, this is important because people don't know the history of this country, particularly when it comes to Native populations. People don't understand the context, the nature of disparities, the nature of poverty, racism, and how history is tied to all of that.
That's it for APHA TV. We hope you enjoyed it. Don't forget that you can replay any of the episodes of APHA TV on the virtual platform and on YouTube. And also, keep up with all the latest developments and get in touch with us via the web. For APHA TV, I'm Dina Baer, signing off. We'll see you next year, APHA.